specialized team. These are things like our white blood cells, antibodies, complement proteins. Complement proteins are cool. Lymphatic system is both transport system and barracks of the immune system. Remember, the cardiovascular system is a circulatory system. It is a circulatory system. The lymphatic system does not go in a circle. There's one way. It starts in the capillaries, collects fluids, and lipids, cellular debris, pathogens, free cells, and that fluid is then filtered through lymph nodes, lymphatic tissue, and then that fluid is reintroduced into the blood. We've combined some of white blood cells in those lymphoid tissues and some of the lymph nodes as well. Not surprisingly, the smallest of the vessels in the lymphatic system are the lymphatic capillaries at the level of the blood capillaries. Fluid is called lymphatic fluid or just lymph. This system is under low pressure. This is much like the veins in our bodies. This system is under low pressure, so it relies on a small amount of smooth muscle in the walls. It relies on skeletal muscle moving fluid around. It relies on valves to maintain unidirectional flow. Very similar. And when that fluid starts to back up, it can leak out into the surrounding connective tissue, cause a lot of that edema that we see in things like I almost said elephantitis. That's inflammation of the elephant. Elephantiasis. You've seen images of this before, right? Where the legs are really swollen. Looks like a big elephant leg. Elephantiasis, not elephantitis. So just like veins, small vessels dump into larger vessels, dumping into larger vessels, eventually dumping into large veins, back into the blood. So you can see that here. A lymph node, you can see we have these incoming, the afferent lymph vessels, delivering fluid that has possible pathogens or white blood cells that have engulfed pathogens or some other cellular debris or cancerous cells even. Coming into the lymph node, there are a couple of layers inside a lymph node that hold different types of cells, different types of white blood cells, for instance, that can now clear this fluid. In other words, take out those bad guys. And then the fluid is reintroduced and drains into those efferent, they're not labeled here, the efferent. These are the efferent vessels. Notice the unidirectional flow with the help of those one-way valves. Lymph nodes can be very, very small. Lymph nodes can be the size of a tip of a needle to about an inch. And they are going to be found all throughout the body, but specifically clustered in areas of the body that are more likely to have pathogens invade. Remember, our skin is our primary immune barrier, keeps things out, does that very, very well. But we do have openings around the face, around the genitourinary system, reproductive system, and of course the lower part of the gastrointestinal system. So we do have entrances into the body. Those are the areas that are more likely to be invaded. Therefore, those are the areas we're going to end up with pathogens more likely in the blood, more likely in the lymphatic fluid at least. And and then more likely destroyed. Lymphatic tissue, surrounded by lymphatic sinuses filled with lymph fluid. Let's see. Go back to this. Like the spleen. The tonsils, the adenoids, appendix. I think we talked about that before, is that the appendix does actually have a purpose. Lymph nodes concentrated in the cervical, axillary, inguinal, pelvic, abdominal, thoracic, supratrochlear areas. That's in the arm. The trochlea. Very well, did it? Upper arm bone is the humerus. Okay, right here, there is a projection. You can see it on the posterior portion a little bit better. This is the trochlea. This is the area sort of the ulna swivels on, and this is the medial aspect right here. So they talk about the supratrochlear. That drains, those lymphatic vessels drain from the hand. So this is not something you'd expect enlarged if there was a trauma to that area, but you'd expect to see it enlarged in infection down in the fingers or hand, especially around the pinky, the medial aspect of the hand, or even like arthritis, rheumatoid arthritis. You can see swelling supratrochlear areas. Now, if these some of these lymph nodes are removed, like the axillary lymph nodes, for instance, are removed, that can actually cause a bit of a backup in lymphatic fluid. It doesn't drain quite as easily back up to the heart. And we would see axillary lymph nodes removed in patients perhaps diagnosed with breast cancer. Have you heard of this before? Mm-hmm. Have they taught you that if a person has had a mastectomy, that you try not to take blood pressure on that side? Because what we don't want to do is we don't want to cause a problem with the lymphatic fluid not easily returning. Because if they've had those lymph nodes out, it's going to cause difficulty in lymphatic fluid draining back. You've heard of this before? Mm-hmm. So what do? They tell you?
Blood pressure on the other
side. Take it on the other arm. There we go. There's the question. I was waiting for it. People ask me this all the time. They come to me and they're like, well, what happens then? What do we do? Why are you guys taking the blood pressure? You're taking it to see if there's any change in blood pressure. If it's dramatically high or if it's dramatically low, right? If it's a little bit high or a little bit low, for first responders, that isn't as much of a concern. So if you come across a patient and she says, oh, by the way, I've had a double mastectomy, you can get a baseline. You can just check their pulse and see, does she have a pulse? Yes, she's speaking to me. Okay, that's all good. Now we know she's, not dead, so we don't have to worry about that. That's one of those times you can just sort of skip it if you had to, as long as you can get an idea. Is there blood pressure? Is there not blood pressure? Is sometimes more important than a perfectly accurate reading. And what if she's unconscious?
You can always do it on her
There'd be
leg.
no way of you to know, right? I'm sorry?
You can always take it on her leg, right?
What if she's unconscious?
I think she's in there.
Oh, I know that. I'm just saying, what if she's unconscious? Yeah, exactly. So, yeah, you can take it on the leg, or you can still take it on the arm. It depends on how important to you is it to find out what her exact blood pressure is. That's the bottom line. Because is it going to cause a problem here? It absolutely can, but is that going to kill her? No. So you have to determine, is it more important to get her blood pressure or not? That's the idea. Yes?
Is it the same idea with breast cancer? Where they have removal while they can't take BP in the heart?
Same idea, yeah. Yeah, because of the possibility of removal or any involvement of the lymph nodes. Get rid of my-
Did they remove the lymph nodes in men too, that have breast cancer?
Yeah, absolutely. Remember, when they find cancer, they have to determine a couple of things. They have to determine how much it is different from the cell that it's supposed to be, and then how much it has remained in one area or moved. So we have a classification of cancer, we have a stage of cancer. And that's what the stage is. The stage is it still in the same place? Has it not moved at all? Or has it moved but just like locally? Or has it moved and is now found in the local lymph nodes? Or is it all over the place? Four basic stages. So, we still want to know how far it went. Adenoid, I said this already. The thymus, of course. Let's not forget the thymus. Let me not forget the thymus. Thymus, very important lymphatic tissue. It's one of the primary lymphatic tissues. Primary lymphatic tissues of the baby's liver, fetal liver, bone marrow. Lymphatic vessels exiting lymph nodes go into lymphatic trunks. Trunks going to be named for their areas, and those are going to eventually go into the ducts, which are going to go into the veins. So this is where the fluid then dumps back in. The thoracic duct. You can see the thoracic duct. That's the big main one. Thoracic duct. Like most of the fluid drains eventually into the thoracic duct, and then the right lymphatic duct takes the rest. So you can see where some of these organs are. Come back to that in just a minute. Good. This would make a better chart. Something with arrows so you can see it. Blood to tissue, tissue to lymphatic capillaries, capillaries to vessels, vessels to nodes, nodes to vessels, vessels to trunks, trunks to ducts, and then back into the blood again. The spleen, spongy organ, has a consistency of a nice ripe peach, but it does have a capsule around it to add a little bit of structural integrity. Found in the upper left quadrant of the abdomen. Do we know where the spleen is located? Have we seen the spleen before? Can I use our dummy?
I don't think it likes to be called that.
It would have been funnier when you just walked before Jesus said it. He would have been like, I don't know,
Huh?
tell you later.
What should we call him then? Big dummy? Hey, big dummy. That's Sanford. Break that. Stomach. We know where our stomach is located. Transverse colon. Lots of intestines, small intestines. Pancreas. Here's our spleen right over here. Here's our spleen. Notice our kidneys are still the furthest back. Here's our spleen. The spleen is important because there's a lot of blood capillaries that run through it. It is a storage area for blood. Not only does it act like a giant lymph node, but it is a storage area for blood. It also helps to take out old, defective red blood cells. Do you remember that a mature red blood cell does not have a nucleus? But it comes from a hematopoietic pluripotential stem cell, which does have a nucleus. So where do those nuclear parts go? Well, this is one of the places where they get extracted. They get taken out in the spleen. You'll hear about the white and red pulps of the spleen. Spleen is not an essential organ. Well, in children, it can be a little more troublesome if this is destroyed in children. One of the ways this is often destroyed in children is actually sickle cell. Sickle cell will cause a young child to be asplenic at an early age. And of course, in adults, it is commonly injured in things like automobile accidents. If this opens up, if it tears, you have a lot of internal bleeding. Okay. What else? Oh, mono. Have you heard of mono? The kissing disease? Mononucleosis, infectious mononucleosis. This often causes splenomegaly, spleen tenderness, and an enlarged spleen. This is why doctors will tell those patients, if they're diagnosed with mono, not to go out and play football, even like afterwards, even after the healing process. They don't want to have that, catch that elbow in the spleen or do any heavy lifting, because that could cause it to rupture. Splenomegaly.
How is that tied to mono? Isn't that a...
Yes, which is caused by what? What causes it?
Strep?
No.
Virus?
There you go. Starting to catch on, aren't you? If you don't know what causes something in the body, what do? We blame it on a virus. And if we're going to blame it on a virus, which one are we going to pick most of the time? Epstein-Barr virus. And guess who we blame for mononucleosis? Epstein-Barr virus. And doesn't the spleen act like a giant lymph node to take things out of the system? That's how it enlarges, much like tonsils enlarge with strep throat, or enlargement of other lymph nodes because of cancer. That's exactly what happens. This just happens to affect the spleen. That's why you shouldn't kiss people. They're dirty, filthy creatures. The thymus, we've seen the thymus, right? Where's the thymus located? Posterior to the sternal bone. And what is unique about the thymus?
It gets smaller as you get
It
older.
gets smaller as we get older. That is odd. We don't expect that to happen. We expect organs to continue to grow as we grow. But not this guy. He actually gets smaller. The thymus has a role in taking these immature cells, these immature white blood cells, and making them mature. So with immune defense, the thymus is very important. Most important when we're younger. Also acts as a type of, sort of like a lymph node. Thymus secretes thymosins. It's not up there. Okay, thymosins is the hormone that stimulates the maturation of the other cells. Oh, here's cancer. What is cancer? The simplest definition, what is cancer? Cells that have changed. They're your cells, they're not cells that came in from the outside world, they're your own cells that have begun to change, that have taken on a different appearance, that are not maturing like they're supposed to. So they're different and they're not doing what they're supposed to do, and they often grow fast, which means they're going to require a lot of nutrients. Which is why we see these people in these advanced stages, these patients, in these advanced stages of cancer. What do they look like in the advanced stages of cancer? What does their body look like?
Very thin.
Very thin, wasted away. Why is that? Because the cancer is using all of those nutrients that they should be using. The rest of the body needs. And of course, if we are going to target and kill rapidly dividing cells, you can imagine that a side effect is going to be the destruction of our own rapidly dividing cells, right? And these would include things like endothelial cells, skin cells, hair cells, things like that. So I've seen the problems with the treatments. Cancerous cells can hitch a ride with the lymphatic fluid. Metastasized cancer. Metastasized cancer, metastasis. This is the spreading, right? Liver cancer, for instance. The most common liver cancer is actually not liver cancer. The most common liver cancer is metastasized cancer to the liver. So it was something else that actually spread to the liver. So if you find in your patient that they have some sort of tumor in their liver, then it's probably the result of some cancer somewhere else that spread to there rather than actually being a liver cancer. Will they know that? No. Well, they might, I don't know. Initially, not until they get a diagnosis of cancer. If they know they have cancer, then they know that if it's in their liver, it probably didn't originate there. So like if they know they have cancer, if they know they have breast cancer, and then they say there's also cancer in my liver, they probably know at that point it's not liver cancer, it's just cancer that is spread. And that, of course, is one of the very common places for it to spread. So this is actually, I think what I just said, the stages of cancer. Stage 1 cancer is in its same place as it moves. Stage 2, nearby tissue, so it hasn't left the area. Stage 3 has gone to lymph nodes. Stage 4. This is, again, is why they will do those frozen sectionings in surgery when they're taking out a tumor. They will have a section that gets sent straight to the pathology department. Surgical pathology department will take the specimen, they'll fast freeze it using like liquid nitrogen or something similar, and then they will slice it and put it on a slide and send it to the pathologist, all while the patient is still under anesthesia. So they'll be able to determine, if they need to enlarge their margins, if they need to look in other places for the cancers, in other words. The immune system is comprised of cells, chemicals, and barriers. Some are active, some are passive, some come with us, and some we learn. Antigens. All of those proteins that are sticking out of our cell membrane that are unique to us, these things we call antigens. Proteins sticking out of the cell membrane that are unique to us, we call antigens. This is how the body decides whether a cell belongs or it does not. If it looks like us or if it does not look like us. If it looks like us, it lets it pass. If it does not look like us, it starts to destroy it. Hopefully. If it does attack its own cells, then we call this an autoimmune disease. That's the immune system That's the immune system making a mistake. Thinking something doesn't belong, so it jumps on it. Yes?
Do twins have the same antigen? Identical twins?
No, they're still going to be different. There's still going to be some variation. Because even though these things are genetically programmed, the environment that we're in is going to alter things. So as they go, that's why even identical twins aren't necessarily going to be an exact match for transplant. But they will be the closest you could get without being there. Antibodies. Antibodies are what our bodies make or that will attach to foreign antigens, hopefully. This will have several effects. This will mark and identify them so that our other immune cells can rush in and do the job, do their thing. They also have the ability to cause them to sort of clump together, which can aid when you're trying to fight these things off, so they don't have the ability to spread much. They also have some potential in destruction themselves. They also cause the complement cascade to activate, which can introduce a whole other problem to this foreign cell that we'll see in a little bit. So antibodies are pretty important. Antibodies, by the way, are also called immunoglobulins. The term immunoglobulin is a fancy term for antibody. Antibody, immunoglobulin mean the same thing, just like thrombocyte and platelet mean the same thing. Immunoglobulin and antibody mean the same thing. The reason that is important, and that is important for you to know, is because there are 5 classifications of antibodies. I call them MAJ. It's easy to remember that way. So they are antibody M, antibody A, antibody D, antibody G, antibody E. But they're often referred to as immunoglobulins. So it would be immunoglobulin M, immunoglobulin A, immunoglobulin D, immunoglobulin G, immunoglobulin E. However, immunoglobulin is abbreviated capital I, small g. So I don't want you to get confused when you see capital I, small g, capital M. Because all that's saying is antibody M, immunoglobulin M, immunoglobulin A, E, G, and E. They have different functions. These two activate what we call the classical pathway. Immunoglobulin A, although all of these are found in blood, most immunoglobulin A is actually found in body secretions. So think of sweat, tears, breast milk. Immunoglobulin G is important because it can cross the placenta. So this is the one that actually goes from mom to baby. So baby gets some initial protection. This we see in hypo. Sensitivity.
Why do you have a question mark on B?
Don't know what it does.
Who doesn't?
I don't. Do you?
No.
Okay, now we don't. Does anybody else? No, the rest of us don't either.
Does anybody?
No,
That's
no. Unknown function. Although there's speculation, but it's unknown function. I don't think you need to know these in great detail, quite frankly. But I like for you to know what this represents. Because when you talk about antibodies, I want you to hear in your head, antibody and immunoglobulin mean the same thing. Because then you'll see this somewhere, IgM or IgD or IgG or something. And I want you to make the connection in your head that all they're talking about are antibodies, the thing that our body makes in order to fight something foreign off. And I want you to remember immunoglobulin G is the one, just for your own sake, I want you to remember immunoglobulin G is the one that crosses the placenta. And I want you to remember that A is the one that goes from breast milk. Because think about that. Yes, if you and your wife or you had just had a baby, you're going to want your baby to get as many antibodies, as much protection as it can. So it's going to get a certain amount from the placenta that's going to cross over. And then when people say, well, should we use breast milk or not? You know, should we breastfeed or not? I'm a big fan. I think that's a great idea because of this reason right here. Introducing these other antibodies.
I'll let you recommend breastfeeding. So you have the next child.
No. The next going to kwashiorkor. I would say up into 2 years is about good. As far as antibodies, the first year, not 2 years, 18 months. Sorry, 18 months.
You kill
A
people.
year and a half. The first 6 months to a year is really, really important. They get those. Part of the reason is because if a child has has a disease where maybe the thymus is missing, for instance, they can't produce a lot of these other cells, or they have a bone marrow issue, they're going to have low antibody numbers. So this will just help guarantee that they continue to have some. But, you know, I know people, they breastfeed 4 years old, or at least use breast milk. That's a little late. That's a little late.
In kindergarten.
Yeah. That's a little late. For immunity, that's what I would say. Innate. Oh, okay, that's what I was saying. Innate. This is what's often called inborn immunity. This is what everybody has. Everybody's equal with, hopefully, has the same basic components. These are things like your skin. But there are also specialized cells that are just, their job is just to just sort of gobble up stuff that isn't supposed to be there. Very generic. Good, actually a good statement here. Innate immunity can only recognize that something is not you. Can't really identify who it is, they just know that it's bad. Adaptive immunity, this is the part of your body that remembers, that can make changes. Adaptive immunity is usually not faster, at least not initially. But it's better. It's more precise.
Is that like allergens?
Like allergies? Yeah, there's yes, yeah, it's definitely a hypersensitivity. But there's different types of hypersensitivity reactions. There's different classifications of those as well. This is where I say things get complicated, where a person has to be exposed to something first, you know, or that it doesn't happen until quite a while after the initial exposure. Delayed sensitivity.
What does that mean by attacking the pathogen on coupons? Does that mean that both an adaptive and innate? Or is that
Yes.
just talking about?
No, it's both adaptive and innate. Well, adaptive there's a primary and secondary adaptive as well. The primary adaptive is the first part that comes in with those cells that can become memory cells. And then the secondary part is the actual part where it does remember, where it makes those extra cells that can make the antibodies.
That's cool.
So there's a primary and secondary adaptive.
That's the secondary is the memory one?
Yeah.
Is that-
Yes, although the primary part still involves the memory cell because it involves the one that says, I'm going to collect this information so I can remember it. And so we can pass this information on. Imagine, okay, I'll do it this way. All right, we have a generic bad guy coming in here. And he has antigens that do not look like us. So, this guy stumbles across him. Just happens to be in the neighborhood, and says, hey, you don't belong here. And takes him, gobbles him up. This is part that we all sort of have. We all sort of have these sort of cells that can just do this. But then this kind of cell can also be an example of a dendritic cell, a type of cell that will gobble this up and say, now I know what you look like, so I'm going to pass that information on to this cell. No, let me do it this way. I'm going to skip a step, just make it'll actually make it easier. We'll skip the helper T cell, we'll go right to the B cell. So he gives this thing to another guy, says, I got this thing came in, this guy looks like this, he's a bad guy, this is what he looks like, this is his name. So that gets passed along eventually to this guy, called the B cell. Some of the information that gets passed along with it is that not only do we know what it looks like, we know, I guess this would look like an Erlenmeyer class, we know what kills it. So here's some information about this new guy. We know what he looks like, and we know what kills him. Eventually, that information gets passed along to the B cell. The B cell then changes into a plasma cell. And the plasma cell makes antibodies. Part of that memory. Part of this primary step in here was this one cell that was involved in this. Can now become additional cells just like himself. He can divide. So that can help pass the information on that we got a problem, pass the information on that we have an infectious, for instance, infectious agent, for instance. That's part of the primary part as well. Or adaptive. Well, what's unique about these antibodies? The thing that's unique about these antibodies is that they fit like a key fits a lock onto these antigens. So if you were to, look at those antigens under a super strong, brand new micrograph. If you were to look at those, if you were actually able to see them, you would see that they have a very unique pattern of protein. So these antibodies, which always have the Y shape, these antibodies have a component that fits that part of that protein perfectly, just like a key fits in a lock. That's how close these things are. The reason for that is the next time this comes into the body, these things are floating through the blood, are going to snap onto it like magnets. And they're going to light it up and say, hey, look, we got this guy over here, and he's a bad guy, oh, and this kills him. So now all the cells that are rushing to that area are going to destroy him before he gets a chance to get inside a cell and create a problem, or get anywhere and create a problem. That's the secondary part. Remember, when you get a vaccination for hepatitis B, that doesn't mean you're impervious to hepatitis. I mean, that doesn't mean hepatitis B cannot get into your body. You know that, right? Do you know that? You know that if you have been vaccinated against hepatitis B, and you're working with a needle, and that needle has blood in it that is infected with hepatitis B, and you get stuck with that needle, you do realize that you will now have hepatitis B inside of your body. It's not like a force field, right? Well, the difference is, now we have a memory cells and antibodies that can act on it quickly before it has a chance to become a problem. Basically, the way we do this is like this. Basically. Remember what is a virus? A virus is bad news wrapped up in a protein code, right? What is the dangerous part of the virus? The dangerous part of the virus is the bad news. That's the dangerous part. So if we take that bad news out of the equation, what are we left with? A harmless protein coat. A harmless example of what this virus looks like, right? So now we introduce that into the body. We introduce this harmless viral shell, if you will, into the body. The body sees it, knows it doesn't belong because it sees that the antigens are foreign, knows it doesn't belong, and so it's going to gobble it up. And it's going to take this message and send it along. Very effective. We also do this with what? With the influenza. Flu shot every year. Well, here's the thing about influenza. Influenza looked like this last year. This year, influenza looks like this. What's that mean?
It's different.
It's different. A little different, but it's still different. So these antibodies aren't going to be effective. They're not going to lock on. So what are we going to have to do? Make a new vaccine. And we do. And then, of course, every year, a person has to get a flu shot. Now, here's the kicker. What do people say when they get the flu shot?
It gave me the flu.
I'm sorry?
It gave me the flu.
It gave me the flu. Oh, the next couple of days I felt horrible. All those things that are happening in your body that make you feel horrible, what's doing that? Your body is doing that. Why do we have a fever?
It's fighting.
To kill. Right, kill these things off. All those things that are happening, all those feelings that we get are the result of an immune response. So it's not the actual virus causing it, it's our body causing it against the virus. That's why those people say, oh, I always get the flu right after I get it. No, you don't. You get signs and symptoms of it. But they're much more mild. Now here's a big problem. The big problem is HIV, human immunodeficiency virus. Human immunodeficiency virus is a big problem because today it looks like this. Tomorrow it looks like this. The next day it looks like this. The next day it looks like this. The The next day, it looks like this. How do you make a key that to fit a lock that changes that quickly? Right? That's the tough part. It's the fastest mutating virus we know. That's what makes it dangerous. That's what makes it tough. Now, if there's a protein that is always the same, if there's that one protein that's always the same, all we have to do is find it. And if we can find it, then you can make a vaccine. If that protein even exists. I'm assuming, since I've thought of this, people who are exponentially more intelligent than I am have also thought of this. And there's probably been research on this. And there might be, there might not be a protein that exists like this. Here's what Ebola does. This sneaky guy.
That was my question.
That was your question? Okay. Here's what Ebola does. Normally, a cell has these different proteins, these different receptors that will bind with our cell, that will sort of like hit the correct key code. And the cell will allow it to come in. All it has to do is to bind to the receptor, or our own receptor has the right code, and it'll just allow that virus to come right in, or at least the viral DNA or RNA to come right in. This guy has his covered up. This is what Ebola does, basically. It has those binding sites covered up. So it does not just fuse with the cell and go inside of the cell. You will see later on when you study this stuff that if a cell is infected, it knows it's infected. And it will take that information and put it on the outside of itself and say, help me, I'm infected with this, so that our cells can come in and kill it. What this does is instead, it allows itself to get engulfed. And then once it is inside of this protective lysosome, I'll draw it as a worm here, the very popular Ebola worm shape. Once it is inside, then these little coverings come off. This guy thinks he's dealt with it, you know. He's engulfed it. Now it's safely inside of this vesicle. Well, it's not, because once it's inside, these are released, and now this guy can bind and move right through this cell. And in here and start making copies. And that's a problem. With HIV, he specifically targets the helper T cells. And the helper T cells are the ones that act at this level here. So if you take out that very important component, you can't make more of them. You can't, divide, make more and more copies of the cell, and it can't go on and pass on that other information. This is why one of the things they monitor in patients who have HIV is helper T cell count, CD4 count. It's helper T cell and its CD4 is the same thing. And then they also want to see if there is any evidence of any sort of opportunistic infection. Those two things, when the CD4 count is low and there's an opportunistic infection, then they say now the patient has AIDS. The CD4 count has to go below 200 cells per cubic millimeter, where it's usually somewhere around 1,000. Anywhere between 500, 700 to 1,500 is normal. Anything under 200 cells, that plus the presence of an opportunistic infection, then we say the patient has AIDS. And please do not perpetuate the term full-blown AIDS. I know people are still using that. There's no such thing as full-blown AIDS. That's like being full-blown pregnant. You know, it either meets the criteria or it does not. These books are still printing them. Physical barriers, you know, those are skin mucus and digestive enzymes, fluids, etc. Do you need a break? Want to take a break? Take a break. We'll take a break. I know it's just rain. We'll take a break. We'll come back at 11:30. When do you want to take lunch? 12 or 12:30? 12:30? 12? 12:30? 12:30? Oh, 12:15. Split the difference.
Let's do it. Compromise.
What do I do?